Difficult to manage asthma, DTMA, occurs in 1 out of every 6 people living with asthma and puts people at higher risk of exacerbations and even death, which are preventable with effective management. Difficult to manage asthma is distinct from severe asthma, and primary care professionals should work on identifying the reasons for poor control before referring to a specialist asthma clinic. Difficult to manage asthma is defined by poor control despite the apparent best possible treatment. These patients may experience daytime symptoms more than twice a week, nighttime awakenings, 2 or more annual exacerbations requiring systemic corticosteroids, use of their reliever inhaler 3 or more times per week, poor control despite high-dose inhaled corticosteroids, or frequent primary care contacts or emergency visits every month. Begin by confirming the diagnosis. In patients presenting with apparently difficult to manage asthma, it is important to first confirm that the diagnosis is correct. Over 1/3 of presumed asthma cases are either misdiagnosed or complicated by overlapping conditions. Start by reviewing the clinical history for evidence of variable airflow limitation and symptom patterns consistent with asthma. Then, if available, use objective tools like spirometry, peak flow variability, blood eosinophils, and FeNO testing. Also consider asthma mimics such as vocal cord dysfunction, dysfunctional breathing, anxiety, deconditioning, and obesity-related breathlessness. After confirming diagnosis, conduct a structured review. A regular planned structured review is essential to improve detection and care of DTMA. At each review, assess the following. 1. Asthma control by asking about daytime symptoms, nighttime awakenings, reliever use and activity limitation over the past 4 weeks, ideally with a validated tool such as the asthma control test. 2. Tobacco dependence by asking about current or passive smoking. Smokers are nearly 50% more likely than non-smokers to be hospitalized for asthma. At every consultation, ask about tobacco use, advise about effective ways to quit, and act according to the patient's response. This approach is called very brief advice, VBA. 3. Patient education and self-monitoring by discussing asthma knowledge, daily impact, recent life changes, and providing a personalized action plan. 4. Aggravating factors and triggers by identifying allergens, occupational or environmental exposures, and exercise patterns. Many triggers are avoidable. Address indoor mold, dust mites, biomass fuel combustion, and outdoor air pollution, and consider infections in children. 5. Pharmacotherapy by asking how and when medications are taken, any side effects and other treatments. 6. Adherence and inhaler technique by exploring barriers such as fear of steroids, cost or forgetfulness, and observing device use. Up to 80% of people do not take inhaled corticosteroids, ICS, consistently and make inhaler technique errors. Assess and correct at every review. 7. Obesity by discussing physical activity goals and appetite for weight management support. 8. Psychological support by screening for anxiety and depression and asking about social networks, ideally with a validated screening tool such as the PHQ-4. After a comprehensive review, refer if needed. If, after 1 or more of these structured reviews, after addressing all causes and triggers, and after guideline-based treatment, the patient remains uncontrolled, refer to a specialist clinic experienced in difficult-to-manage and severe asthma. In your referral letter, summarize main symptoms and control level, number of exacerbations in the last 12 months, current pharmacological and non-pharmacological treatments, quantified oral corticosteroid use, adherence and inhaler technique assessments, comorbidities, lung function and biomarker results, known allergies, and tobacco use. Remember to schedule regular follow-up. Book follow-up appointments with reasonable intervals tailored to the patient's needs, ideally every 1 to 3 months initially, and then every 3 to 12 months once control improves. Finally, remember, our Desktop Helper number 2 provides a deeper look at difficult-to-manage asthma, including questions for the patient, the PHQ-4 screening tool, and more. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.